So we are going to continue on with our chapters to talk a little bit about the clinical management of pain, and really the importance of part of the medical history, action plans, and then the theories. When we get into our Gen Med, we are going to talk more about the pharmacological agents that are a component of it. Okay? We all know that the physical exam is really important. Okay? You have to do it. You have to interview in order to help with your diagnosis. Um, some things are going to be very clear and other ones are not. So trauma can lead to fracture, which then is going to have pain. Okay? But also we have to do some deductive reasoning. Okay? Especially when you don't know the specific onset of injury or pain. So you have to ask some really good questions in order to get to maybe what is going on. Okay? And we call that the PQRTS format. Okay? We need some provocation, which is, how does it happen? 2, we're going to ask for the quality, meaning the characteristics of pain. So aching, and that may be some kind of sensation. Burning says nerve irritation. We're going to ask if it's radiating or referring somewhere. And that's going to be, is it peripheral or is it going somewhere else? Radiating pain can mean a lot of things. S is for the severity. So even though it's subjective, how severe is it? And then T is the timing of it. When does it occur? Night pain may indicate something that's more chemical, or another musculoskeletal problem of activity can say it's later on. So again, the timing of it is really important of it. And we are always going to ask them their characteristics of pain. So we really want them to do this, to be able to identify, what their pain is like. Okay. And so one thing we always have to remember, especially with referred pain, is you treat the injury and not the site. Okay. And always asking that timing of it. When does it occur? Okay. And those referred pain patterns can be different as well. We all know that if you're having a heart attack, you might have pain in the left shoulder, neck, and jaw. Appendicitis is going to be in the lower abdomen, right groin area. Kidneys are going to be in the back. Okay? But we're also going to ask them on a pain scale. And so we have these different types of pain scale questionnaires. 1 to 10, or we do a visual analog saying no pain and unbearable pain. We also see the happy faces that are done as well on these different types of assessment scales. We do have, different types. Just be consistent with it, and especially how you're explaining it. Okay. Now, we have those visual analog scales. It's really helpful. And again, you can look up different types of indexes that are out there. Okay. We also know that pain can cause mental anguish. It can change sleep pattern. If it changes sleep patterns, it's going to change how you're going to think, how you feel, how you process information. We also know that there's going to be, previous pain experience. If you got into a car accident, you might react differently to a secondary car accident just because you remember the pain that you have gone through. So we have these different types of theories, which I mentioned the gate control theory before, and then it also has been modified. And, they're really trying to figure out what it is. And so in the original one, it was called the gate control theory of pain. And basically it said, explained why modalities controlled pain. And it basically, because of that, it led to TENS. Okay. But we learned so much more about the system. Okay. The pain system, especially through like advanced testing through MRIs and PET scans. And so the evolution, okay, of the theory basically is Dr. Melznak, who's been studying pain forever. Basically, it's just talking about the neurosignal patterns of nerve impulses that happen all throughout the brain. So again, we have this cognitive and visual and emotional influence that really contribute to the neurosignatures, okay? and it can generate sensory input independently or within the brain or by the brain by itself. And so it really, your neuro matrix really has a motivational, effective sensory discriminatory system of pain. So we have this modulating of pain, okay? We can help change some of these components of pain, such as we can desensitize or slow down the velocity of pain transmission on a myelin sheath, but just by using cold. We can use medications that will block some of these receptors of pain. We can also use a subsensory to decrease the levels of pain. We use microcurrent, okay? And we can also use part of the immune system to be able to do this. So, in this gate control theory, which still occurs, what he used to say was at the gate, there's this mechanism that opened and closed at the dorsal horn. It either increases or decreases the noxious stimulus that's going up, and that it opens the gate until it lets it flood in and flood out. Now what it's saying is, we really understand how much the brain modulates pain in the descending signals to the dorsal horn. And so we can actually decrease some of those pain components because of the big influx and the attributes of different components of the brain working at the same time to decrease the pain. Enkephalins, beta-endorphins, endorphins, looking at that model can really inhibit some of those transmissions of pain. And again, that's all going to occur in that substantia gelatinosa, okay? And that's those where that A beta fibers are going to first be activated. Okay? There's our A beta fibers and our A deltas, okay? All information coming in. And we're going to draw all of this out in class. Okay, when we have pain, we basically can have this feedback loop that occurs of noxious pain stimulation. Okay, serotonin, noxious inhibitories, controls, all occur with that pain modulation. Okay, and this is endorphins where we can go from low frequency to high frequency with contractions. What we can do in this descending pathway when pain is like that, we can use some nerve blocks to completely stop it. And so we really need to take a really good health history here, look at referral patterns, okay, and get quality information. Just because someone is in a rest cycle and they are not feeling pain does not mean that the pain cycle is gone, okay? So sometimes we have to look at what needs to be actually corrected. It's not just always a straight up injury. It might be a chronic component that needs to be treated. And again, this myofascial pain syndrome, there's usually a multi-pronged approach. Okay, we talked about trigger points, which we will look at, and we talked about how in the forum how it's really chemical, and we need to break that chemical pain cycle. And we're going to be doing some of these techniques in class.